طيب بسم الله الرحمن الرحيم. So this is our third session to talk about the other unique pathophysiology we see in cyanotic congenital heart disease, which is the poor mixers, and I'll explain by what do I mean by poor mixers or poor mixing. So it is cyanotic congenital heart disease. We have said before that to be cyanotic, you have to have a right to left shunt. You may be more cyanotic because of decreased pulmonary blood flow, or less cyanotic because of increased pulmonary blood flow. But there is another reason that has nothing to do with right to left or decreased pulmonary blood flow that can make us cyanotic, which is not quite common, alhamdulillah. It is the poor mixers. Let's follow again, just to refresh, our normal pulmonary, circulation, which we call circulation in succession. You know the 400-meter contest where they pass the baton, as they say. So it's somebody who runs for a distance and then gives it to the other and gives it to the other until they reach the end of the track. And that's how the body is. We send the blood from one area to another, passing all the areas and then coming back to where we came from. No shortcuts in between and nothing different in between. We call that circulation in succession. It produces a lot of benefit. You know, in the racetrack, they can cover 400 meters easily by 4 people, while one person may not be able to cover it in the same faster time. So circulation in succession is a gift to have, whether in you or in the racetrack. So let's go and see how is it circulation in succession. If we start by the pulmonary venous blood flow from the inferior vena cava and the superior vena cava, when it reaches the right atrium, it gets directed to the right ventricle, from the right ventricle to the pulmonary artery, from the pulmonary artery to the lungs, to the pulmonary veins, from the pulmonary veins to the left atrium, to the left ventricle, to the aorta, to the descending aorta, back to the body, and then back as a venous return to the IVC and superior vena cava. That's circulation in succession. We can say it: venous return, IVC, SVC, right atrium, right ventricle, lungs, left atrium, left ventricle, body, and then back to the heart. So if we can simplify it more, it's body, heart, lung, heart, body, heart. That's how it is. So let's say it again. It is body, venous return, heart, lungs, heart, body, arterial supply, body, venous return. It is in succession. Nothing in between escapes. There is a condition called transposition of the great arteries, which is shown in this picture. Mind my drawing, it's not the best, but transposition of the great arteries is a unique cyanotic congenital heart disease that has poor mixing. And let me explain why. It is because of circulation in parallel. It is not in succession. Circulation in succession is a circle. From one side, you go through many stations and come back to the same cycle, like here, and so on. But circulation in parallel is actually 2 circuits going on parallel to each other, not crossing each other, not mixing with each other, not talking to each other. And obviously, that's even not a good thing to have. You don't want to be a loner. You don't want to be not communicating or not connecting or not interacting to be a good person. The same goes to pathophysiology of the heart when it is transposition of the great artery. So let's follow the blood and see what it is. And when we say transposition of the great arteries, we mean the great arteries are transposed. The pulmonary artery, which originates from the right ventricle, in this case it's originating from the left ventricle. The aorta, which originates from the left ventricle, it is in this case originating from the right ventricle, and so on. So let's see how the blood is going. The IVC, or the inferior vena cava blood, now goes to the superior vena cava blood, to the right atrium, to the right ventricle, and up to the aorta, going to the body, coming back to the right side, and so on. The pulmonary venous blood flow comes from the lungs to the left atrium through the pulmonary veins, to the left ventricle, to the pulmonary artery, i.e. back to the lungs, and going back to the heart, LV, lungs. So you see now, what do we mean by circulation in parallel? Let's say it as words. So, body, venous return, RV, body, body, venous return, RV, body. So it's really body, RV, body, body, RV, body. That's not good. The blue blood, the deoxygenated blood, is not taking its normal pathway to go to the lung to get oxygenated. It's just passing in a closed circuit from the body as a venous return to the right ventricle, to the aorta, to the body, and a venous return. So obviously, it is one severe form of cyanosis, because the whole blue blood is trapped on the right side, which sends the blood back to the body, to the aorta, not to the lung, and comes back to the same trap. And because there is no connection between the left side, which has the oxygenated, the red blood, and the right side, these patients are extremely poor mixers. There is nothing mixing, and that's why their cyanosis is one of the worst. So can a person like this live? Obviously, it cannot go like that. It will be just a few minutes to a few hours, and the patient will be dead after birth, because of such pathophysiology with no mixing at all is not livable. So usually these babies are born with a patent ductus arteriosus, which is open from the aorta to the pulmonary, and that provides a source of mixing. The blood now, the trapped red blood, can now cross and go into the aorta, and hence the patient starts to become less cyanotic or livable. And that's why transposition of the carotid arteries, when they are born, we may not notice the cyanosis immediately, because the ductus is usually open and providing the mixing they need to become enough saturated. And that's why it's very important to do pulse oximetry on all newborns. You can miss easily a TGA patient, baby, because of good mixing through a duct, which we know will close with time, and then becomes back to the original pathophysiology, which is poor mixing, but that may be quite late. The baby may have gone home, coming back with severe cyanosis, severe acidosis, and even arresting. Another area where we mix when we are just born in TGA is the patent foramen ovale. We usually have a small hole in the interatrial septum, and that also allows the red blood to cross to the right side, mixing with the blue blood and making the saturation higher in the right atrium, higher in the right ventricle, and obviously higher in the aorta, making it livable. In a few days, maybe a few hours even, this may close and the PDA may close, and then you will see the true pathophysiology of transposition of the carotid arteries, which is extreme cyanosis because of poor mixing. A third type of pathophysiology of cyanosis that we do not see in other diseases. What's unique here is those patients are an emergency immediately after birth. They need a source of mixing to be maintained to live, part of this poor mixing pathophysiology. So these patients will not live well without a ductus. And once we diagnose them with tetralogy of with transposition of the carotid arteries, we start them on prostaglandin, PGE, to maintain the patency of the ductus. And usually that's quite enough to provide them with the saturation needed until they get the corrective surgery, which is today an arterial switch operation. The aorta is put back on the pulmonary valve, and the pulmonary artery is put back on the aortic valve, and the coronaries are transferred. So this kind of cyanosis is severe. It needs a mixing site. Sometimes the PDA is not an enough mixing site for transposition of the great arteries, and we have to revert to increasing the size of the PFO or patent formal oval, making it an ASD rather than just a small hole. And this can be done in the first few hours, first few days of life, interventionally by cardiac catheterization, going from the venous side with a catheter and a big balloon here. And this balloon is pulled against the septum, making what we call a balloon atrial septostomy. And that's usually good enough to provide them with a sizable defect that can give them sizable mixing to improve the saturation in the right atrium, right ventricle, and hence in the aorta. And obviously this is all temporary because they will need the surgery for the arterial switch. There are other types of surgeries. Some unique part to this kind of pathophysiology is that the myocardium here is supplied through, obviously, the coronaries, isn't it? The coronaries in this disease are seeing blue blood. So the myocardium, immediately after birth, is also seeing blue blood. So we do not be surprised if we get myocardial dysfunction or myocardial ischemia causing myocardial dysfunction if the cyanosis gets added. So heart failure, myocardial dysfunction is also a feature of the pathophysiology of this disease if not corrected, and it's even a feature of post-surgical coronary transfer, but that is not part of the usual normal pathophysiology. That's kind of a surgical or post-surgical pathophysiology. The other thing in transposition of the great arteries is that they usually have wet lungs or what looks like pulmonary edema. And this is because the cardiac output on the left side is going to the lung and is trapped there, no mixing, plus they are receiving from the aorta the intercostal arteries and the bronchial arteries supplying the lungs, and that extra flow also makes them pulmonary venous edema. That's another feature that adds to the pathophysiology of these patients. So if you leave them, they may go into heart failure, more pulmonary edema. They are already cyanosed, now they have pulmonary edema and may have even worse ventilation, oxygenation, and that adds to the problem. Plus, obviously, they can become severely systemically acidotic because of anaerobic metabolism due to severe cyanosis. By this part, we would have completed the three main pathophysiological features we see in cyanotic congenital heart disease. We talked about the ones with increased pulmonary blood flow with excellent mixing, having acceptable saturations, being more susceptible to heart failure, having usually no limitation to pulmonary blood flow, but they are susceptible to heart failure and pulmonary hypertension because of unlimited pulmonary blood flow. We talked about and we gave the example of total anomalous pulmonary venous drainage in such increased pulmonary blood flow class or classification. The other one, which is the decreased pulmonary blood flow, and we have the example of tetralogy of Fallot, where we have the obligatory right to left shunt across the VSD to the aorta from the right ventricle. and that's totally deoxygenated blood going to the aorta, causing significant cyanosis. That cyanosis may be increased or decreased depending on the other pathophysiological factor, anatomical factor, which is the presence of subpulmonary stenosis and pulmonary stenosis. The severity determines the amount of pulmonary blood flow and the returning oxygenated blood, and also the amount of the right shunt. The more obstruction in the subpulmonary or the pulmonary valve, the less flow, the more right to left shunt, the more cyanosis, and the less obstruction, the more flow, the less right to left shunt, and better saturation. We also talked about the hypercyanotic spell, which is unique to congenital heart disease like tetralogy of Fallot because of the dynamic obstruction below the pulmonary valve. Tachycardia increases that, and they may have more cyanosis because now the obstruction is really faster happening and more strongly happening. We talked about finally the poor mixers, where it is not a matter of right to left shunt or decreased pulmonary blood flow. Actually, in transposition, there is increased pulmonary blood flow, yet they are still extremely blue because the circulation is not in succession like in the normal side, where it goes from the venous return to the right ventricle, to the lungs, to the left atrium, to the left ventricle, and then to the aorta and the body, and back to the right ventricle. Actually, it is in succession, where the blood flow or the venous return goes to the right ventricle, to the aorta, back to the right ventricle, to the aorta, and the lung or the pulmonary blood flow goes from the lungs to the left ventricle, to the lungs, to the left ventricle again, closed circuit, not mixing, and that's why they demand a mixing site, which is either the PDA or the ASD. Occasionally they will have a VSD, and the VSDs do not play a big role in the pathophysiology of transposition in the area that it really does not provide a good mixing site unless it's a huge VSD, and that's not usually the case. The usual case is a small VSD just near the perimembranous area or the subpulmonic area. Actually not the subpulmonic, just in the perimembranous area, because if it is in the subpulmonic, then they are really different type of transposition, which is not the goal of this presentation and this explanation, because there are many types of transposition depending on VSD location, presence of pulmonary stenosis or not. We're not going to make it too complicated. We're just talking about the mainstream pathophysiology of cyanotic congenital heart disease. Thank you for your audience, and see you inshallah in the next part, which is talking about left to right shunts and their pathophysiology.